Good afternoon. I would like to call the Cuyahoga County Finance and Budgeting Committee meeting for Tuesday, June 21st, 2022 to order and ask the clerk to please call the roll.
Just as a reminder to all who are in attendance, this meeting is being recorded and live streamed on the county's YouTube page. Calling the roll, Mr. Miller,
Here.
Mr. Tuma,
Here.
Mr. Jones,
Here.
Mr. Gallagher,
Here.
Mr. Schrein,
Here.
Ms. Baker, Ms. Turner.
Here.
There is a quorum.
Thank you very much. That's perfect attendance. That's terrific. And number 3 on the agenda is public comment. Has anybody signed in?
No, Mr. Chair, no one is signed in.
Item number 4 is the consideration of the minutes from the June 13th, 2022 meeting. Do I have a motion regarding those minutes?
I'll make that motion.
Second.
It's been moved and seconded to approve the minutes from June 13th. Any discussion? Hearing none, all those in favor say aye.
Aye.
Any opposed say no. The ayes have it, and the minutes are approved. Items referred to the committee is item H from Resolution 2022-0128.
Item H from Resolution Number 2022-0128, 2345-opioid mitigation. The Office of Budget and Management, on behalf of the Office of the County Executive, is requesting appropriations of $10 million in the opioid mitigation funds. Cuyahoga County has developed an investment strategy that focuses on the mitigation of opioid addiction with the intent to find solutions to the problem. A group of subject matter experts will be instituted as a governing board to hear innovative technologies or strategies tackling opioid addiction and make recommendations for finding such options, while at the same time leveraging funds from other investors. The funding source is the Opioid Innovation Fund. The period of performance will be January 1st, 2022 to December 31st, 2023.
Thank you very much. That item is now before us, and here is where we are. At the council meeting, the one before last, this item was on the regular fiscal agenda, and the council decided to hold that item for further discussion, which we're having here. And so we're going to have that discussion today, and we don't have to formally vote on the item. It's a matter of the committee determining by consensus whether we're okay with the item proceeding, and if we come to a favorable consensus, then the item will be put back on the agenda in a future fiscal agenda. And directing the presentation is going to be our Director of Economic Development, Paul Hertig, and Annie Ritkers, who's our lead consultant on the project, is going to be making a presentation, and also Dr. Jennifer Bruner from Metro Health Hospital and Ray Leach from Jumpstart will not be formally presenting, but will be available as needed to answer questions from the committee. Director.
Thank you. Good afternoon. Paul Hertig, Cuyahoga County Department of Development. First, I'd like to thank the council president and Councilman Miller for their consideration in scheduling this meeting so we could have a more full discussion of the administration's proposal to use money for an opioid innovation fund. We appreciate the time and attention of each member of council to what we feel is a very important issue. I'm going to very briefly frame the proposal and then going to turn matters over to Andy Ritkers, the consultant we've been working with for some time to develop this proposal. As Councilman Miller stated, also present today are Dr. Jennifer Bruner of Metro Health. Dr. Bruner occupies a role in Metro Health determining what sorts of innovative practices it's going to consider for as part of its work. And Ray Leach, the CEO of Jumpstart, also present if needed as a resource with considerable experience in early stage investing in all sorts of innovative products and services. Briefly stated, we're here because the serious problem of opioid addiction continues to ravage our county. Director Brandy Carney, also here, has spoken to you many times about the issue, and council has authorized spending considerable amounts of money from our opioid settlement funds for various activities to deal with the impacts of opioid addiction, especially on treatment. That's very important, and nobody is minimizing the need to continue to provide resources for treatment. But as we continue to see terrible numbers of our people impacted, and there was news over the weekend, for example, that the number of young people, of children who've died from opioid is now over 100,000. As we continue to see this, we can't help but say to ourselves, can something more be done? And there is a history of applying innovative techniques, both practices and products, to solving difficult problems that we believe is important here and is worthy of consideration of substantial county resources. Why is the Director of Development speaking to you about this? Because supporting innovation in dealing with the opioid addiction crisis is not unlike supporting innovation in dealing with other facets of economic activity. Advanced manufacturing, for example. Just in today's Cranes is the announcement of a $2 million fund being set up here in Cuyahoga County to invest in early stage advanced manufacturing companies, because those investments will lead to better products, better services that will lead to their growth and improve the economy for all our residents. So there is an established way of looking at investing in innovation. It is not without risk, and we are not suggesting that Cuyahoga County directly become an investor. Among other reasons, we're not allowed to. Under the law of the state of Ohio, we ourselves cannot act as an equity investor with our public funds. What we are advocating, however, is the wisdom and necessity of taking a substantial amount of money, up to $10 million, and placing it in an appropriate place with appropriate oversight and guidance so that money can be invested in what appear to be promising technologies and systems for addressing opioid addiction. Now, we are here today talking about an appropriation, and again, we appreciate the consideration of council leadership in letting us brief at this stage. With the approval to proceed with the appropriation, the next stage will be returning to council with a full grant agreement with the Cleveland Foundation. So there'll be another opportunity for hearing and discussion at that stage. We can, however, and will today, give the general outlines of the way we plan to proceed with this $10 million appropriation. There's really three portions to the work that will be done. One portion is to enter into an agreement with the Cleveland Foundation to place the $10 million there as what is often called a donor-advised fund. Cuyahoga County places the money there. It is held safely by the Cleveland Foundation. They have considerable experience in safeguarding large amounts of money. It's what they do, and will then be further dealt with by the foundation. The second part, more important, is there will be an advisory board that will be named by county leadership, including this council, to advise on the use of this $10 million. So any decisions where to invest the money will be brought before this advisory board, which will be able to weigh in, use their expertise, their points of view to determine which are appropriate investments of the funds. And the third part of this will be a small portion of the money to be determined through competitive bidding for actual management of the fund, no more than 5 to 10%, by a firm to be established through bidding that has experience in managing funds that are invested for innovation. The intent is that, guided by the advisory board, county named, Over a period of about 3 years, the fund will seek to make investments of various types in technologies, both products and processes that bear on preventing and having innovative treatments for opioid addiction. This is to be done over a period of about 3 years. We anticipate that within a period of 5 years, we will see the results of these various investments. Now, when Annie Richter speaks, she'll go into more detail about exactly how this is proposed to work. What I want to emphasize, though, is that we, the administration, have not pre-selected any particular investment. We are not going in saying we've already decided where the money should go. That is the reason for having the panel of expert advisors. Using their collective wisdom, their awareness of what's going on in the field of opioid prevention and treatment to be able to evaluate what the best investment opportunities are. The other thing that our funds will do by being our funds is they will allow us to take advantage of the fact that here in Cuyahoga County, we have a strong system of health care with multiple public and private entities, many with a public connection, and we have a population which is typical of a large urban area where there is a great need for these kinds of treatments and prevention to happen. So the investment advisories will be guiding those investments to those which they judge to have an opportunity and a potential for substantially aiding right here in Cuyahoga County. Now, Annie will talk in a little more detail about how they do that, but the short version is we will look for opportunities to have these innovative products and processes actually tested here so that they can be tested in ways that can be exploring how they will help our own residents deal with this problem. And by testing here in Cuyahoga County, this will ensure the benefits of the investment come to our residents and will encourage the companies that we're investing in to consider Cuyahoga County as a strong partner in these investments. So that's the overview in a nutshell. I'd be happy to answer any questions now, or if members prefer, until they've heard the more detailed presentation at that time as well.
Okay, Councilman Toomer.
Thank you, through the chair. Mr. Director, as far as the advisory board, is this a board that already has been put into place through the administration, or is it something that's still a work in progress? Like, for example, how many individuals would you see, would you like to see on the board, and what the qualifications would be, or is that something that council would put together?
Thank you, Councilman. First, this board does not currently exist, so we're not talking about using an existing board. This would be something created specifically for the purpose of this fund. I will defer to Annie to go into a little more detail about the specific qualifications. Besides, generally, we're seeking a combination of several types of expertise. One is expertise in understanding the medical issues involved. A second is expertise in understanding investing in early stage companies. And a third, very important, is understanding the needs of our community. So it may well be this board will include among its categories of membership those who actually have personal experience with having dealt or with having their family dealt with opioid addiction, to bring that point of view.
Appreciate that. And then, and this might be better addressed by the expert here. As far as a time frame for this, you mentioned a 5-year look back at investments. Is that what I heard you say correctly?
Yes, thank you, Council. We anticipate being able to move, fairly speedily towards getting it set up. That it will take about 3 years to place all the money in investments, and our anticipation will be to have investments chosen that will show definitive results within a 5-year period. Some may come considerably sooner than that, but that's the outside horizon for when we want to see that results would be coming.
And so, if I just could, through the chair, what would be the, perfect ending to, this entire plan here? Is it to see a reduction in the opioid crisis in this area, or is it going to be a continuous attempt at keeping opioid addiction down, or what is the end game here? I guess is what I'm looking for.
Thank you, Councilman. I will say, not being a medical expert myself, but as one who works on the business side of things, that our hope would be to, as we say, move the needle, to show that the technologies and processes that our fund supported made a significant impact, downward impact, on the rate at which people are addicted to opioids.
Appreciate it. Thank you very much.
Councilman Gallagher is next.
Paul, what was the genesis of all of this? And who or whom have we spoken to in the medical community, having the luck of all the institutions that we have here in Cleveland and Northeast Ohio? Who has been consulted before you got to the podium today?
Thank you, Councilman. I am not in a position to give a complete answer to that question. I will only speak from my own knowledge. My own knowledge is that we have engaged with Metro Hospital as one of the hospitals we work with in discussing these opportunities. And in terms of inspiration, I want to acknowledge both this is something the county executive feels strongly about, and I do want to acknowledge Councilman Schrond, who's been an early advocate for taking this approach as well. We have spoken with Jumpstart, as evidenced by Ray being here today. I will pause here. There may be others that I have not personally worked with that others may be able to speak to.
My only concern, this is a pretty big ask of what obviously is one of the poorest communities and one of the more at-risk counties, Appalachia also being a problem here in Ohio regarding opioids. So I'll be interested to see where we go. Considering everything that we've done to date, which has been substantial, and knowing that we have the medical examiner here who deals with this on the ground, I would hope at least minimally he was consulted before any such ask like this would move forward. Right. But I'll let it unfold and see where we're at.
Councilman Schrond.
You alluded to on Mr. Tooma's questions about structure and the way investment opportunities like this sometimes take place as far as councils and panels and things of that nature. I think that you do have Mr. Leach here that actually speaks to innovative ideas and concepts and things that have done in the past. It seems to me that that would be very, very beneficial. How do you structure this? Because it sounds to me as though it would look an awful lot like the same kind of investments, only in a different field than what the success of Jumpstart has had in the past. So I would encourage us to actually hear how he goes about putting that together for a Jumpstart when they look at an analysis and the projects and things of that nature. So they've been very successful, obviously, for the last 10 years plus, and have instrumentally moved the needle in a huge way in a very, very long list of different areas and activities. So I would encourage that. And perhaps maybe to answer, I think, some of the concerns that Mr. Gallagher asked, there were also folks from the innovative side from Nottingham SPIRC that were actually involved. If you perhaps wanted to make sure you got their information in regards to it, who Nottingham SPIRC, of course, is probably the most innovative company in the entire Northeastern Ohio. Their history is world famous, and innovation in both medical and mechanical things. And there's not a one of us that probably doesn't have one of their products on their desk, or I mean in their bathroom right this moment, more than likely that they innovated as far as new technologies. Thank you.
Okay, please continue.
Thank you, members of council. At this point, I will bring forward Annie Ritkers.
Good afternoon. Welcome to the committee.
Thank you for having me. Hi, my name's Annie Ritkers. I run a firm called 17A, which is a consulting firm. and I have had the privilege of working on this project. I've been working for more than 10 years with state and local governments on public health and Medicaid-related issues, including addiction and behavioral health. And also in my spare time, started a nonprofit that is focused on bringing innovation to frontline addiction treatment providers in the Cincinnati area. And that's been around for 4 years and is called RealWorks. So maybe where I'll start today, we prepared a presentation. And I think, probably not news to anyone in this room, unfortunately, but the opioid epidemic is obviously something that has gotten an increasing amount of attention over the last few years and resources and a lot of, great investment and engagement from leaders across the community and the state. But despite that, we still see that overdoses are on the rise. And so, this morning I pulled the latest CDC data, which is on the chart in front of you, and that's just showing how overdoses have changed between 2015 and today. The nature of this problem is such that we're doing a ton, and I think there's still a ton of room to try new things so that we can actually get at some of the root causes that are causing that problem to persist. So the impetus behind this work was really informed by 3 big goals. So I'll get into the goals and then would love to talk through some of the designs that we've put forward that will actually help meet those goals. The first goal, front and center, is having real local impact. I think it goes without saying that every dollar that goes into this problem should have some direct benefit on residents of the county. The second is, making a contribution to what we know about what is going to fix this problem from a root cause perspective over the longer term, which is a big goal as well. And then the third one is actually producing some sustainability for the county. So, I think there are different forms that could take. One is an actual financial return. Another is producing assets that can be used for other forms of innovation and community advancement later. So we'll get into that as well. So before we get into the more interesting elements of the design, just wanted to start with a little bit more detail on what Mr. Hurtig described as the design for this. So the idea is that $10 million would be used by 3 groups, basically, who would be the stewards of these funds. The first group would be the holder of the funds, so that would be an organization like Cleveland Foundation that has not been selected yet, and they would actually hold the funds on behalf of this initiative. The second group, which would be a critical ongoing decision-making body, would be the board of advisors that was discussed earlier. That has not been selected, but the premise is that it would have 3 types of community members involved. Public health experts locally, of which we all know there are many, technology and innovation experts locally, also many in the area, and then third and equally important, community experts who know the needs of the county well. And then the third group at the table would be the program manager, who would actually run the program that would be used to use the funds that we'll talk about in more detail. These are not all the groups that would be involved. We'll talk about this in a bit, but the whole idea of this is to actually bring lots of stakeholders to the table from the business community, the healthcare community, and the patient community to actually have an impact. So we'll get into how those others are involved in a moment. We are calling this Solutions for Opioid Innovation, and the idea is that this would be a fund that would support innovation from companies or other early stage groups with ideas that have new solutions that have the potential to address the opioid epidemic in some way. We would imagine around 3 years of active work putting these funds to work, and that the returns would all be realized over a 5-year life of the initiative. Great. Okay, so what would this look like, and how would it actually work? So on the left-hand side of this page, you'll see, the 3 big things that the investment from the county would include. And then on the right-hand side is all the intended outputs. So as far as what the county would be bringing to the table here, the first we've already talked about is obviously a substantial financial investment. The second is the creation of light program infrastructure that would be built on top of all of the great existing infrastructure that Cuyahoga County already has for healthcare innovation. And then the third would actually just be the county's ongoing commitment through this fund to bring additional resources and stakeholders to the table in an ad hoc manner when they would actually be useful to any of the individual investments that the fund makes. So what would this produce? So the first and foremost, goal of this is actually new learning. So, I don't think the initiative should undertake something if we already know what it will produce. So every investment would actually have a lot of insight into what works and potentially what doesn't. The second is, and we'll talk about this in a little bit more detail, but success-based repayment for any of the projects that are funded through this initiative. If they have the desired result, the county would actually have the ability for the fund to get a return so that it can be sustained and do, more with that funding over time. The third would just be the creation of a test bed that is functioning, that can work on this issue and be an asset for the county more broadly. And the last, and we'll get into this a little bit more, is the ability to actually focus innovation on this topic on, parts of the community that this group and the advisor group thinks is most valuable. So for example, the Medicaid population. Great. So I know with the word investment and fund, a lot of people's minds go to venture capital. While venture capital plays an important role, there is a difference between the role the county's funding would be playing and all the venture dollars that have gone to this in the past. So in the last 5 years, there has been an enormous amount of investment in behavioral health, which includes addiction services. And, it has produced a lot of focus on technologies that are typically marketed towards employer-sponsored health plans that are, providing coverage to individuals who have a lot of resources. So the county's investment would be different in that it would actually focus on specific populations that are typically last in line for innovation. And it would also be different in two other important ways. One is that, unlike equity investment, the investment that we envision here would actually be used for direct services. So it would be paid to companies for things like pilots, that we will talk about in more detail in a moment. And those funds would actually be used to provide services to county residents who are struggling with addiction and would get supports through a pilot. And that is very different from how traditional venture investment works, where you write an equity check and then the startup has to go look for customers and end users. As part of this work, we were actually talking to several groups that, are active in this space from a business perspective. And one of the founders that we talked to, who runs an addiction treatment related startup, actually said, we need customers to know that our technology works. I'm doing this because I want to help people, and it's great that everyone wants to write us a check, but what we actually want is people to use our product to show that it's effective so that we're actually driving better outcomes. And so the county would actually be playing that role through the pilot model that we're proposing. And then the other thing is that, the county would also have the ability to prioritize areas within the space that have historically gotten a little bit less funding. So prevention-related things typically haven't gotten as much funding, for example. So that could be a focus of the initiative. Okay, so we've covered a lot. Paul covered the three types of investments that the money would, or three pockets that the money would go to. The first one, by and far the largest, is pilots. So the idea of a pilot we will get into more detail in a moment, but this would be use of technology and new types of innovations with actual providers in Cuyahoga County, for example, someone like Metro Health or a federally qualified health center, and their clinicians using something new with their patients through a pilot to see how well it can work to drive better outcomes. The second example would be more traditional. So we would imagine a smaller portion of the funds, more like 20% to 30%, being spent on traditional early stage innovations, and we're calling them smaller bets than the pilots. And that would be, things that just need a little bit more funding to actually scale. And then the last part, necessary to anything like this is 5 to 10% of the total funds over 5 years to be spent on operations to actually run this. Great. So maybe I'll just go through 2 examples of how we would imagine this working, and then excited to hear from everyone on their questions. The first, and these are just examples to bring the pilot idea to life. The first example we brought is a company that is called Mommy, and its focus is on driving better outcomes in maternal health, and they have a great track record doing that. They have not built out any specific focus on moms with opioid use disorder, and there's a lot of room to use this tool in very innovative ways to actually drive outcomes for that group. So what we've written up here is actually an example where a group like Metro locally would be the provider in the pilot, and would agree to work with a company like Mommy that has tools that help their clinicians actually understand of all the moms that they're treating, who is most at risk of missing their next appointment, what patient might need an automated reminder, how can that clinician actually learn a little bit more from the addiction treatment specialist that is working with that patient to make sure that their care plan for their maternal health is going well. So Mommy does all of those things and could be a tool to support that clinician in caring for that mom. So in the pilot, we would actually look at the effect of the use of that tool on the moms that the provider in that pilot is working with to see what types of better outcomes we can produce. So the way that we would imagine the funds working in that, the county money would be the initial kind of risk capital to say, we think this is an idea worth trying. So the first part of that pilot would be with a small group that the county would fund, and the county would fund it with the commitment that if it meets certain metrics, then the provider that is at the table, so for example, Metro, would commit to actually using that more and paying for it. And so in the second phase, Metro would actually pay for the use of the platform directly to the company, and then the company would pay back the county with a return if that phase 2 happened. And so in an ongoing basis, the company gets to see that Metro is committed to paying for something it values because it's driving the right outcome, and the county is getting a return when that outcome is met. Great. And then for the other type of examples, so the more experimental investments, this is a little bit more traditional, so we probably don't need to spend as much time here. But, there are a lot of companies doing interesting work with products as well on this topic. And so one is the company called Believe. And again, this is just an example, but they have basically created like a dispensing pill bottle that makes sure that you're only dispensing your pills according to your prescription. So as we know, a lot of misuse of opioids leads to a lot of addiction down the line. And so Believe is managing that upstream by actually controlling dispensing so that only the person who is prescribed can unlock the pill bottle, and only for the amount of the drug that has been prescribed. So that's all we prepared for today. I know that's quite a bit of detail. Hopefully it answered some of the questions on people's mind, but would love to hear if there are any more questions from the group. And I know Paul was going to come up again as we take more questions.
Thank you very much for the presentation, and I'll open it up to my colleagues for any questions or comments. Council President.
Okay, thank you. And thank you, Ms. Rickers, for the presentation. Councilman Gallagher actually asked a very important question. What was the genesis of this? And what I heard was county executive's name. But what I didn't hear was a hospital, Cleveland Clinic, or anyone driving this. You brought in the presentation, the venture capitalists. The question for me, though, is that's where, to me, a lot of this should begin. I'm still not grasping why we should come in. I still see it as stepping into the role of the venture capitalist. The Cleveland Clinic does it. You know, they invest what they want to. If there's some, project or invention worth investing in, they do it. How are we? Help me understand why we're not actually competing with them. Where are we filling a gap?
Thank you, Council President. And in a moment, I'm going to impose on our colleague, Dr. Bruner from Metro, because what I want to state is that the investment is linked to our public health system locally, our health system locally, being able to work as a test bed. And that's a little bit different from the way you normally think of like the clinic or UH trying to sell the technology they've developed in their labs. So the traditional model of commercialization is one of the researchers at the clinic invents something, and then they go out and they sell it into the private market and attempt to make a lot of money. What we're recommending here is investments in things that don't get that kind of attention. I think something Annie said was very important here. The traditional model focuses on being able to get to market and make a lot of money, which means it's marketed to those who can pay. Those who have great health insurance tend to get the most treatment options. What we're bringing forward is an intent to develop treatments, innovative treatments that are aimed more at those that aren't rich, those who perhaps rely on Medicaid, those who tend to be treated at a public hospital like Metro. So what I'd like to do, Council President, with your permission, maybe after another exchange, is give Dr. Bruner a little bit of time to talk about how Metro selects the kinds of treatment, innovative treatments they are willing to participate in.
Okay. Still, the idea of $10 million. This is a significant amount of money that you're asking, and asking for us to put it into the Cleveland Foundation, to simply move 10 million of these critical dollars, and we have to determine how to best use them. And I'm still concerned, are we really talking about the best use of $10 million taking and giving it to the Cleveland Foundation for a pilot? Pilots don't typically start at $10 million, pilot. And at that dollar amount, I would expect Akram Boutros to be here. Why is the CEO of Metro not here at a $10 million ask? So those are just my initial thoughts.
So if I may, Council President, first of all, thank you. To be clear about the proposal, it is not to invest the $10 million in any one initiative or any one thing. The function of the advisory committee is very important here. It's not just to pick one place to put 10 million. It's to choose a number of promising innovations to support in two different ways, as Annie said. So way number one would be if there is a technology or a process that's out there, but it needs a test bed, it needs a place to be tried out, some of the money in the fund would pay the fees for that technology to be used at a hospital like, for example, Metro, for a startup period. So I'm reducing the risk so that Metro doesn't have to start risking all its own money, but is supported in making the decision to be a place to try this new process, this new product. And in addition to that, as Annie said, there'll also be some investments, smaller investments in brand new startup innovations. So the idea is to spread the investments around among a number of different promising innovative processes and projects, not all in one place.
So even at that, my thought still goes to $10 million. A pilot doesn't start that high. And even if you have, as you just mentioned, particular projects, it could be project by project. $10 million just go over to Cleveland Foundation. That's challenging for me.
Right. I understand, Council President. Thank you. Again, I want to make sure we're being clear. We're not giving the Cleveland Foundation control over the $10 million. They're functioning as a community foundation in what's called a donor-advised fund, where the donor, which in this case is us and our advisory board, retains significant control over how the money is being invested. So their function here is to be the trusted holder of the money and have the capacity to manage this scale of funds with no risk, no concern of the money disappearing. But the role of the advisory committee is extraordinarily important in making sure these are directed to the appropriate multiple investments. And if, Council President, I believe Annie has additional comments, if I may.
I just think holding the money, we can hold our own money, but please continue.
Thank you. The only thing I was going to add is that, I think we could expect between 6 to 10 pilots easily from that amount of money. The other thing I would say is I would actually view the institutions like Metro as also giving here. I think others can speak to this more directly than I have, but I've been close to quite a few pilots, and providers actually have to give quite a bit. They're doing something new. And so it takes leadership, like someone like Dr. Bruner's time, clinicians logging into something new. So I would expect that would actually be quite a big commitment for the providers to take on. So I think the county's initial investment as a way of kind of sweetening the pot for what's already hard about healthcare innovation is one thing I would add to that.
I remember Akron Boutros being here several months ago. Their commitment to behavioral health certainly is without question. And at that time, they certainly didn't put a dollar amount, but they were certainly here discussing monies. So again, I just say if they were there months ago and he's not here today, so.
So at this point, Council President, with your permission, and I want to be clear, I'm not asking Dr. Bruner to speak for Dr. Boutros. We've invited Dr. Bruner in a more limited role, which is to talk about how she and her team make decisions about when to commit the time of their doctors to testing a new process. So with that understanding, I'd like to ask Dr. Bruner.
And she is serving ably in our own county jail, is that correct? Correct about who Dr. Bruner is and her role in the county? Okay.
So, Dr. Bruner, if you don't mind.
Good afternoon. Welcome.
I'm going to bring this down just a little. There we go. So I'm Dr. Julia Bruner from Metro Health, Senior Vice President for Behavioral Health and Correctional Medicine. And the team asked me to attend today to share partially the potential of practicing some of these innovations and piloting that in Metro Health's space. But I could see this as an opportunity for many facilities to do this. This is not a Metro Health singular interest, I think, in this space. The other thing I would say is Metro is very interested and has had great success in innovating care when we look at it from a population health perspective and the perspective of really assessing what the needs are from patients and hearing from patients as to what they need to be successful in their health. And so that, I think, any program that we would be partnering or interested in participating in would be one that we know has an interest in relation to the patients. Does that help?
Thank you.
You're welcome. Any other questions before I step away?
I have a question. Mr. Chair.
Okay, so Ms. Baker hasn't had a chance yet, so we're going to go with Ms. Baker first and then back to Councilman Toomer.
Thank you. And thanks for I've heard this before. I think it was in a different committee. This is all familiar. I can't remember which committee it was in, but I've seen this presentation before. So, it seems to me that all the opioid issues that come to us or come for need of funding is all reactive. It's all, we need funding because the opioid is increasing and more funding is needed to help those. So I'm hoping that today what we're hearing is more proactive, that we're trying to find out, and I think the word root causes was spoken, that we talk about what exactly causes someone to begin to go on opiates. Is it perhaps recreational? Is it from an injury from work? Is it physicians prescribing it and patients get addicted? What exactly, unless we know where it's starting, how can we possibly come up with innovative ideas in order to prevent it? And I guess I'm really hoping that that's the direction this is going in, not so much as with the example with Maumee, where we are helping those with treatment. How did that mom get on opiates to begin with? And what can we do to impact that? What innovation is there to reach out to understand why people are going on opiates to begin with? And is there anything in this proposal that puts funding aside to understand the behavior of why people not only are on opiates, but it's also increasing in its usage? Unless we understand why, I don't know how we can possibly be innovative to try and stop it. Can you have an answer for that?
Thank you, Councilmember. That's a great question. I think we don't want to reinvent the wheel on another committee to re-examine that. What we would rely on is the advisory board having expertise in that area. So the advisory board would certainly have public health experts that would have that background. And I think just to connect it to the actual activities of the initiative, prevention has come up a lot. And I think there's quite a bit of interesting activity with companies and organizations creating things that have the potential to impact prevention. So the pill dispenser is one example. I think people have probably heard about safe prescribing tools that clinicians use who are prescribing opiates for the first time to someone, prescription drug monitoring. So there are a lot of potential solutions in that space that I think could be ripe for a pilot or investment through this fund. And I think looking at the root causes through the expertise of the advisory board and some other groups that they might want to call on, if that's an area of focus, would be how that would work.
I may follow.
Please.
During my time at the Ohio House, there was, again, another huge increase in opiates. And I was part of a task force that went across the state of Ohio trying to figure it out. A lot of them were rural areas, urban areas, although we learned also that demographics doesn't really matter. We have addictions across the state, doesn't matter what family background you come from. And things like when a doctor prescribes a prescription for a minor, the mother must understand what it means to be on a controlled substance. Things like doctors not being able to give 6 months in advance, opiates. They must, every 30 days, come back and say why it is they need more. Many, many different precautions of trying to be proactive before that addiction even starts. Is that a direction that we're going in here, or is that just maybe one of the pieces of this, and it's more about different types of treatments?
I think ultimately it's up to the advisor group to prioritize. So either could be the direction, but we had envisioned room for both. And, I think while there are many great solutions to treatment, I think it would be great for the committee to consider things that make existing a treatment more effective. I think we've all learned a lot about, social determinants of health and other factors that can make healthcare solutions that are only medical harder to work. And so, there are quite a few innovations that I think should be considered on the treatment side as well, but it ultimately would be up to the advisory committee to prioritize between those two. And they're both obviously hugely important.
Okay, thank you.
So Councilman Tuma is next, followed by Sean.
All right, thank you. Through the chair. To Mr. Herdig, you mentioned various processes and projects that would be a part of this. Like, what are you referencing? Are you referencing what the councilwoman referenced as far as programs, or, I mean, I'm
Yes.
trying to figure out
Thank
exactly.
you. First, I should say of the three people before, I'm probably the least expert on this area. However, I do work in the Department of Development. We handle money. So I'm going to give an example which may seem a little far-flung. Trying to predict the stock market in order to decide where to put your money to protect yourself from this terrible inflation we're having now. Well, investors are willing to pay an awful lot of money for advice, and smart people have spent a lot of time trying to invent software algorithms that help an investor predict the safest place to put their money. So now put yourself in the shoes of a general practitioner who has a patient who has pain from a back injury and is trying to figure out what's the safest way for me to prescribe for my patient so I can have the best outcome, so they don't have the least chance of getting addicted. One of the products we're talking about might be an app, a system, a software system that a GP can use to put in, here's the information on my patient, here's the kind of pain, their age, all the things that research shows us are important. And that app would then guide to the doctor, make a suggestion, doctor, it appears based on the evidence, your best course of treatment for your patient is the following. That's the kind of innovative process we think might be supportive by this fund, and then test it out in our community settings to see if it in fact is improving outcomes.
So my question then would be, and I appreciate that example, it makes it a little more tangible. My question would be, though, and maybe the doctor can answer, wouldn't Metro Health have something like this in place already from experts who do this at Metro Health?
Dr. Julia?
Making suggestions to doctors who are looking, for innovation,
So at Metro, we've done a lot of things in relation to innovation when it comes to substance use disorder.
Right.
We have dedicated teams working at the jail in relation to reducing substance use disorder through MAT. We have the Office of Opioid Safety that's out providing syringe exchange and engaging people in a variety of different stages in relation to their opioid use disorder. We have multiple addiction medicine clinics available.
Right.
And we've done a lot of work to reduce the number of narcotic prescriptions per encounter, per individual, in an effort to Mrs. Baker's statement around reducing the number of prescriptions that are out there.
Well,
And so when you talk about algorithms in relation to artificial intelligence guiding the right medical treatments, we are doing that in many ways in healthcare. And much of the work that's done in addiction is very multifactorial. There's a genetic component to addiction that I think we all know and understand. And there are also social aspects to it as well. And so there are opportunities to improve this such that maybe a provider at Metro Health may already have access to that, but there are other docs that don't work in hospital systems that us piloting something to create some research and some support for it would then allow that person to have the comfort in relation to using that technology to help their patients.
Okay, no, that's very helpful. I appreciate that. I guess my question then would maybe be to the director. So why not just have streamline this and have an advisory board who are made up of experts who can make recommendations to the surrounding hospitals or Metro Health or whomever,
Thank you. Councilman, the added factor is, in addition to making recommendations, being willing to put resources behind it. So the idea of the fund is that the advisory board is armed with some money it can direct. So then rather than simply saying, we believe it's a good idea to take all these factors into consideration, as Dr. Brunner said, the board could also say, and we think it's such a good idea, we're willing to devote, say, $500,000 of the fund we've been entrusted with to, and giving this money towards a company that's developing the technology to let GPs have that same expertise.
So why not having it? I'm just talking out loud here. This is what we're doing. We're in a committee. Why not just have an advisory board who then comes to county council with a request on a specific funding, project for funding, as opposed to saying, here's 10 million, who knows what, what can happen with 10 million. Telling, I have some of the same concerns as the council president. That's just a lot of money.
Councilman, as someone who's worked in the public sector for a career, there are times when the speed with which the public sector works doesn't always match the needs of business. And one of the intents here is to allow this fund to be able to move quickly when its advisory board, which is county controlled, judges an opportunity as before it. So what I'm trying to say in a careful way is that there's sometimes we in the public sector can't quite get our business process going fast enough to meet what the private sector needs. And this mechanism, we believe, would retain considerable control by the county leadership appointing the advisory board, while at the same time allowing the investments to be made quickly and flexibly in the way the business needs.
Okay, I appreciate it. I just have one more question, and I won't ask any more questions, I promise. What about liability issues? So say, the board recommends something to a technology, and it's used on a patient, and something horrible happens to the patient because it's new and, technology. Who has liability on it? Is that Metro Health? Is that us? Is that you? I don't know.
Councilman, excellent question. And our friends in the law department working with the Department of Development, whenever we do contracting, risk is one of the issues that's covered by the contract. So the contract, if approved by this council, as was noted before, council isn't deciding today to work with the Cleveland Foundation, but if fully approved by this council, that contract would cover those liability issues.
Okay. All right. I appreciate it. Thank you, Mr. Chairman, for allowing me the time.
So, to Councilman Tuma, this is a large investment of money and complex, and I had in mind that we needed a thorough hearing, so you're contributing to that well, so I appreciate that. And Councilman Tron is next.
Thank you, Mr. Chairman. And I just remind council, we just did something very similar to this just a few months ago when we sent millions and millions of dollars to Jumpstart to do this exact same thing. The Jumpstart is the one who's actually making the decisions on those proposals that came in, and the county has handed those funds over. We actually handed those funds over for our minority creation of minority businesses. And so it was focused. This is just focusing on, clearly right now, there's no doubt that Northeast Ohio is the opiate crisis capital for the entire United States. All the cases went to Judge Polster's court. And I just, and Mr. Gallagher, Councilman Gallagher said, where was part of the impetus for this? And I'll accept the responsibility for being a driving factor, because I've seen innovation and how it can change things. And I would not expect Mr. Hurtig to be able to answer some of these questions about what the specifics would be, because if you want to go into some deep thoughts on this as to when they first scratched out the laptop, they said what a useless piece of equipment that was going to be. It would only be used by corporations. And no, of course, it would never be used in the home. When General Magic created the iPhone, it was sat on the bumper for 10 years before it ended up being an Apple-based product. It was almost identical to what General Magic did. The creativity, when you get people like Dr. Bruner here, their limitation is only their mind, and their mind is not limited to anything. And so when you get that kind of creative thought, it's, and there's Dr. Bruners over at the UH, there's Dr. Bruners over at the Cleveland Clinic, there's Dr. Bruners over at the Veterans Hospital. Who knows what service member who is hooked or gets hooked on this? We can't find a solution like the iPhone, like the laptop computer that were all joked upon. And I can tell you personally, when I had this crazy ass idea, excuse my French, about creating an online university around manufacturing education, everybody laughed at it. And last year's class had a little over 800,000 students going to school in. So you never know where this day goes to where the end is going to be, because no one can say that we're doing a good job on treating opioid. We went through 100,000 deaths just this year. whatever we're doing ain't working. The problem is getting worse and worse and worse. And it's not even overdoses anymore. I mean, I just listened to a report just the other day. These are not overdoses. These are sometimes first-time users that are dying of these drugs out there. I mean, I just saw a couple of young men that out in California died, first-time users out of it. So my, to Council President, question about the Cleveland Foundation. It is the first foundation ever created in the entire United States as a community foundation. It has multi-billions of dollars. Amy, Rita, what would be, if there was other folks like Metro, like other funds, would they want to put their money into Cuyahoga County if we were the holder of the money, or would they prefer an independent third party, just like we just did with Jumpstart?
So,
Or either one. I mean,
I do want, and if I may take one point of privilege as Annie comes forward, I do indicate Dr. Bruner has to get back.
Okay.
She has patient care duties, so I just want to mention that in case there are any questions people wanted to address specifically to Dr. Bruner before she has to
Then
go.
let me just revert. Let me go back to Dr. Bruner. Your labs are working on all kinds of products and processes, I can only assume, some of which, if there were other folks that could come out of this fund, could be doing the exact same kind of thought in products and processes. Could your lab be developing things like that? And could this also fund be developing products and processes like, Mr. Tuma just left.
So
like he was alluding to.
I think the value of this is that it creates an opportunity for investment in different research and innovation within the space of opioid use disorder. And it doesn't, for Metro Health, it would be an opportunity that we would look to be involved in. But I would suspect that there are more people, more hospitals that would be interested in this, more FQHCs that would be interested in participating in this. So I see this more as a community-wide potential trial of application in relation to technologies and support, rather than just a Metro Health area of product review.
And I agree, because I think that was what the picture was being painted. What are the communities in the country that have this same opiate problem, have the hospital systems that we have the R&D labs that all 4 of our beautiful hospitals have a diversion center that we just created to stand up to, that we could be doing these pilots? What other places like this in the country are you aware of that would have this vast opportunity like this?
So Cleveland has a lot of opportunity, as you're pointing out, Mr. Schrock. What I would say, the other areas in the nation that are leading in relation to trying to tackle opioid use disorder, that would be in Texas, within San Antonio area. That's another space. Seattle is another area that has a great deal of work in this area. So
On the treatment side, or the development of perhaps solutions that maybe predate the...
A little bit of both.
Okay, good.
Right, a little bit of both.
And it's healthy to have multiple different ideas coming out there. It doesn't make it exclusive. My question was, sorry, Dr. Reeder, was whether or not, if the Cleveland Foundation is an impartial third party, and I know we're not picking the Cleveland Foundation per se today, but would funding of this nature, because you've created funds or been a part of it, would they more than likely put money into Cuyahoga County? Because I don't envision this $10 million is going to be where it's going to stop. You're going to have people from all over the country, I believe, putting money into this to help solve this. Would they prefer to put it into something like a third party, or they put it into Cuyahoga County to be the administrator?
I think that's for Annie, but first I want to note Dr. Bruner is going to have to go back to her clinicals.
Thank you.
Thank you, Dr. Bruner.
Thank you.
I think if the county were to do this, it would be extremely unique. And so many of the groups that we spoke with talked about this as, a differentiator in terms of thinking that they would have support to connect with healthcare providers that would be the right ones to pilot with, and other groups in the community who have access to data and other supportive services that would also make work here on this topic successful. So I think to answer the great question more directly, I think this asset and the county's role in it would be one of a kind. And so, a great example for the rest of the country and ideally a pull for a lot of others to come here and test things through it. I think that would have to be the case.
And I guess
So-
I'll just leave with the final thought that imagine what it would be like if we actually do solve some of the opiate problems on the front end as opposed to treatment dollars that we're chasing at the back end, because you will never have enough dollars to take care of all the treatment based on the growth of, if you could stop one overdose candidate before they die, think about the impact if we could solve it through other solutions other than just treatment. Thank you.
So I have a couple of questions for Ms. Whitkers. And, you know, and I'm hoping you're in a good position to respond to this line of questioning, because you testified you've been working in this area for 10 years or longer. And when I think about the opiate crisis, I mean, it strikes me as one of the most monumental failures of our society in some sense. I mean, it should be like 2 or 3 a year, not 700. I mean, it's like 2 or 3 orders of magnitude beyond what's in any way reasonable. And I'm wondering if you can give us any sense of, why do you think it's so intractable? Why have we been working on this for 10 years or longer and not made any progress? Why are we doing so poorly on both prevention and on treatment? What can you tell us?
I have a couple of different thoughts. Thank you for this question. I think it's obviously a really hard one, so many people would have more things to say about this. The two biggest things that come to my mind, I think we caught it really late, and I think that is the fault of a lot of organizations and levels of society and all of us who are witnessing this. I think by the time we all realized that, you know, physicians were prescribing what ultimately became a death sentence to many, we had a scale of a problem that meant that the response required is just enormous. And even though a lot of the dollars from the settlement are large dollars, they are tiny in comparison to the type of problems that have been created by the time we all kind of woke up and realized that this was front page news, and also in our backyard. I think the other thing about addiction treatment is, a lot of the academic research into what works on this topic has been around. There are many successful interventions that have been around for a long time, and this has typically been a part of healthcare that is funded differently. The whole delivery system is different. It's extremely stigmatized. I think we would struggle to think of anyone we know who has broken a limb and then their whole identity becomes being someone who broke their limb. Whereas you can think of anyone you know who's ever had an addiction, you associate them with being an addict, which is, hopefully something we're all moving away from doing. But I think that had a real effect on the way that research and innovation on this topic was funded and integrated with the rest of healthcare. And I think that stunted us. So I think this part of healthcare has historically really lagged because it's more disconnected. When I started working on this topic, 80% of addiction treatment providers were single site. Most of them were using pen and paper in part of their records-making process. We've made great strides in the last decade on that topic. But, that's clearly not the case for big health systems. Orthopedic surgeons aren't doing things in a single site with pen and paper, and have not been within the last 10 years. And so I think that's another contributing factor because we were so much further behind. And then I think the third one is it's just a really hard topic. I mean, Dr. Bruner spoke to this and knows it better than I do, but this is a multifactorial problem, right? It's a medical problem. There's a lot of social elements to it, including in a person who's suffering from addictions everyday life. To really recover, you're talking about remaking your entire social network, changing all your daily habits. I mean, any of us who've ever tried to diet, I think, know that changing habits is hard, and this is one that is, that's a ridiculous example compared to what people with addiction are trying to overcome. So I think we need to try more new things for that reason, actually, and I think it's just hard to do.
So I think at this point, public awareness has to be reasonable. Probably almost everyone knows one or more people that have died of an overdose. So in the face of that, why can't we get more people to just stop making decisions that are almost suicidal in nature?
Thank you for the question. I think it's a huge question. I think people, all of us in this room, probably make somewhat counterintuitive decisions all the time that are not in our best interest. And I think as someone, I'm fortunate that I've never suffered from addiction. I think that's another issue with this space. Most people who've been working on it is come from lived experience, which I think is really powerful. But I think we need to professionalize how we think about the room to work on this issue. But to your question, I don't know that I have an answer other than that addiction has been the human condition since as long as we've been measuring it. And I think one of the things that's so devastating about this particular epidemic is that it started in, a doctor's office, and also these drugs are so potent. If someone was mentioning first-time users dying, I think with fentanyl, part of the concern is that you don't even know that it's in what you're doing. And so, I wish we could all just make 100% perfect decisions all the time, but I think none of us do. And unfortunately, this is one that has extremely high stakes.
So, can you give us any sense of what kind of innovations would be possible that would be large enough to significantly move the needle on either prevention or treatment?
Sure. I'll just stick with the two types of innovations that we've been talking about, but I think there are many more, and what's so exciting about this is the fund would have the chance to make a lot of choices instead of picking a few. I do think there's room for more decision-making tools with providers. And Dr. Bruner referenced this, but to her point, quite a lot of, there's still room for even the best health systems out there to innovate on how they give providers tools for prescribing and monitoring patients who might be at risk. Certainly with smaller providers, that's the case. And I think the trick with those sorts of tools, so that would be, like a federally qualified health center, a primary care, someone who is a much smaller organization. So I think on the prevention side, looking at pilots of tools with those sorts of providers would have a ton of impact, again, because those types of organizations have a much more limited capacity to do something, the Cadillac version. They need something that's going to work with whatever lightweight tools that they have. And so I think that would be a good place to focus on the prevention side. Could try something like Poleve, that dispensing bottle, and see if it has an effect on certain patient populations in particular. Young adults, I think, could be a good one to try that with, or parents of teens and young adults. And then on the treatment side, I think there's a ton of room to complement regular addiction treatment with other tools that are already working in, anxiety and depression management that could work in addiction services. And so I think the example we gave today with maternal health is one that comes to mind, but, there are lots of tools that also sort of gamify the early parts of treatment. So contingency management is a field that does that. I think that's really interesting. What that does is accommodates for the fact that, the effects of good cognitive behavioral therapy that's at the root of a lot of good behavioral health treatment is over time you're actually rewiring the brain so that you're getting kind of reward type of feelings from things that are more long-term and more fulfilling and not from quick fixes. And so what contingency management does is actually creates that incentive earlier in treatment when that rewiring hasn't quite taken root from the core therapy by, giving people incentives to show up to appointments or if they have clean drug screens. And it's shown to be it's more effective than, anything but Suboxone, essentially, when coupled with cognitive behavioral therapy in actually making treatment stick. And so I think prevention is important. I think relapsing and preventing relapse is also a really good way to stop some of what we've been talking about today.
Do we have any statistics on what percentage of the addictions start from prescribing as opposed to starting on the street?
I am not current on that today, but that has definitely changed over time. If we have the chance to come back, we can bring that.
So, from my line of questioning, it's made it clear that I think what we're doing right now isn't working very well, and that's the motivation to do something that's new and a little bit radical, So I think if there's any field of activity where there's a strong case for that approach, this is it. Councilman Tron.
Yes, Chairman, you had asked about some products, and I hope my colleagues can hear that the mere hint of this idea of coming to Northeastern Ohio, I received calls from people about ideas. One which was from California, as Mr. Hurdick alluded to, this might be coming in as software, might be coming in as coding. It was on a business that had created virtual reality. They wanted to, they would be reprogramming the brain to get off of drugs without using drugs to do that. One of the places that they wanted to work directly with was with our phenomenal hospital system, and heard about our diversion center. The idea that if there was a fund of this nature, they would move and relocate their business to Cleveland, Ohio to help create this solution around code writing, virtual reality, and things of that nature. I mean, all you have to do is envision how much could you unleash of the power if somebody was just to go and create apps like you see on your cell phone with this same kind of intent to do it. Another example was I alluded to Nottingham Spirk. If you are, again, and I alluded to that maybe some of you might have their products, but if you ever used an electric toothbrush in your life that was invented and designed in Cleveland, Ohio at Nottingham Spirk. If you go through the list of one after another of innovative ideas, one of which I had the opportunity, though I'm not, I can't disclose as far as the limits as far as what went on because of an NDA, but the idea that every pill, and I didn't realize it, every pill has a signature on top of it. Everyone in your medicine cabinet has a signature on top identifying clearly what's in Michael's medicine cabinet, what's in my medicine cabinet, and one of the things that we don't do very good currently is dispose of those correctly. This organization has the ability to scan it, identify who's dropping it off, whether it's a nurse, a medical professional, whatever it happens to be, so we can get those drugs off the streets. I think is what you were alluding to, Ms. Baker. What do we do to get it off the street? So if you get 100 pills off the street on the front end, think of what benefit we're producing on the back end. And whether or not, I can only imagine that same kind of technology could identify whether there's fentanyl in there, and we would have saved those 2 young men's lives that we just read about yesterday in the paper. If you could get those, and perhaps, and I want to say it's goofy, but who would have thought that you could do your blood pressure and you could do a cardiac with that little teeny device that they advertise on the TV? What if that was in your home, in your family's home, if you had that available, if those parents had that available to be able to check and see whether there was fentanyl in that microcapsule? Would this county truly be benefiting from an innovative fund if we could develop even one idea like that saves those lives? Because what we're doing right now, everybody says $10 million is a lot of money, and I'm not going to exaggerate that it is not. But we're talking about $140 million that we're putting out just for the treatment piece. What if we could stop those treatment pieces on the front end before they ever got to that? This is what this innovation fund is about. It's the same kind of excitement and energy that you find from a new idea that never existed. I mean, some guy, Edison, the light bulb had never been invented. And so the same thing happens here. There are ideas that are sitting in Metro, in Cleveland Clinic, in somebody's back room that they're working on in their own little medical shop. And I think that this is what this is about. And I agree with Chairman Miller. What we're doing isn't working. What would be the risk instead of taking, we're not even talking 10% of the monies that we got. We're talking about a small portion of the opiate crisis money that we received. What better way to create an opiate solution? Thank you.
So Councilwoman Turner hasn't had a chance all afternoon, so I'm gonna call on Ms. Turner next, followed by Gallagher and Baker.
Okay, just a quick question. What happens at the end of this 5-year process?
Thank you, Councilwoman. Our intent is to write the contract so that in no event will the money be used for anything other than the intended purpose. So hopefully, if investments are made guided by the Board of Advisors that return some funds, that hopefully funds will be returned back into the fund that can be used for future investments of this type. We do not know. There's an element of risk here, as there is in this type of investing, but it is intended to be a fund of money that has some degree of replenishment with guardrails in the contract so it never gets diverted to any other use.
Councilman Gallagher.
We know exactly how this started, and we benefited with a legal settlement. It started with doctors over prescribing. What stopped that was the government getting involved and prosecutions occurring to the point where now if you are operated on, you're not getting sent home with 90 days worth of pills that'll get you addicted. So we know where it started. Why people are dying. For the most part, we know where that came from. That's fentanyl and carfentanil. And we deal with that on a county level to the point where we were ordering refrigeration trucks to hold the bodies. So we know what that is. There's nothing out there that's going to stop the fentanyl people. The only thing that's going to stop that is it's created in China, it's shipped to Mexico, it's processed in Mexico. And if you watch Vice on the cable, they have this woman that's fantastic. She goes undercover and shows you exactly how the chemicals arrive from China in Mexico, how they create the fentanyl and carfentanil in Mexico, and how they get it into the United States. So it's a problem with that. We actually looked at getting dogs for the airports because it was coming through the regular mail, U.S. Postal Service. And then we were told that the dogs have to take time off for like they can work a half hour and have to have 4 hours off, because if they get too good of a whiff, they'll die. And they get screwed up because of it. So this is multi-layered. This is, I think, and I know you don't mean it, this is almost a slap in the face to the people that are trying to help people with addictions as far as traditional services like Charity Hospital and some of the other folks around town. $10 million goes a long way in beds and services. And I don't know about anybody else here, but coming from first-hand situations, getting hands-on help from a human being is the most important thing. And really the most important thing is the individual that has a problem has to recognize it and face up to it, and then take the major step of correcting it. We actually in the county, and I don't know if you're aware of this or not, we put out kits to identify fentanyl. The mind of the addict is so twisted that they were taking the test strips to identify whether or not the dope they were buying had fentanyl. And if it didn't have fentanyl, they would take it back to the dealer to get the stuff with the fentanyl. So this isn't an innovation thing. This is a human on human situation. We are one of the poorest areas in the United States, at least Cleveland proper. We got lucky with the settlement. I think we need to be judicious with this. I'm not against innovation, but if you can get me an app that's going to be put on an addict's phone that can get around the fact that they're going to use that app to identify the fentanyl in the dope that they have, they're going to get that app for that purpose. So this is a multi-layered, very deep problem that we have dealt with now for years. And it's really not our job as the government, local government. I think this is a collective starting with the federal government and our border situation where this stuff is coming over. And one of the reasons that Northeast Ohio is one of the capitals, or one of the first capitals, is because of the I-71 and the Turnpike. They would ship it to Chicago, and halfway between Chicago and New York is Strongsville, Ohio, where I'm from. And that's where they moved it. And our sheriff at the time told at least me, because I was wondering why there were so many sheriff's vehicles on 71, they were identifying the dope coming in and pulling these guys over quietly because there was so much of it. They didn't want the media to know the amount of fentanyl and heroin that was going through Northeast Ohio. And then, of course, it finds its way down to Appalachia, which had an incredible per capita, the worst place in the United States. The worst. And you very rarely hear about that. I'm not against innovation, but I'm very, very delicate with the dollars that we do have. And I will tell you, I started out by asking the genesis of where this started. And I haven't heard anything about that. And you're going to, how did you get here? Maybe you're part of the genesis. I don't know.
So,
I'm asking her a question.
oh, I apologize. Annie?
Thank you.
Did somebody from the county call you and say, come in, or did you call the county?
I
or-
was approached by the county about this idea. Actually, the county approached Jobs Ohio, and we have worked with Jobs Ohio before. I interned at Jobs Ohio many years ago, and they knew that we have worked on the behavioral health issue and addiction treatment, including donating a lot of my personal time to this topic. So they referred the county to me, and the Cleveland Foundation paid for our work. So I was not the only person from our team working on this, but I led our team, and there were several members of our team who worked on it.
Well, I think going forward, at least for me, I only speak for me, is that I would like to see some of the providers of traditional solutions to addiction testify about this. I find it odd they're not here. I find it even odder that Dr. Bruner was here and not Dr. Boutros. And I do understand the practicality of bigger institutions like the Cleveland Clinic and UH, where they're going to, if they create something, they're going to market it themselves. I get that. But to start this whole new board and do all this seems awfully messy with the money that we're talking. It seems that Mr. Tuma, at least for my mind, came up with a better thought, maybe not a solution, but a better thought of having companies come to us through our economic development funds and processing it through that, which we've been somewhat successful. There's been misses and hits along the way, as you would expect. But being one of the poorer areas in Ohio and going into what is going to be a bad recession, there's no such thing as a good recession. I just wonder how wise it is that we're going to take a major step with $10 million set aside for helping those with those addictions. I don't think there's anything we can do to save people that are that are searching out fentanyl, in essence, to kill themselves. And I unfortunately knew one like that. And you're right, we all know somebody, or somebody knows somebody that's died from this. So I don't think it's lack of trying from our side. But to put $10 million out on the street through the Cleveland Foundation, who hasn't been chosen yet, but boy, we're using them a lot, and through a board that's not up and running yet, and putting $10 million for things that, as you said, there's no guarantees. Well, I understand that. But I think it's better if a company comes to us through our economic development process and then makes their pledge through this council. Why do we need a committee? Why do we need to set aside that 10 million there? If it's a good idea, the market takes care of it, and we all know that. So I need to find out where this started, how this started. Is it because we got 100 million plus and antenna went up? Or is this the altruistic presentation that we're having right now that only good people are coming forward? It seems to me a little bit of both, with the providers not being here, Boutros not being here, the clinic not being here. They seem to be thrown out there as partners in this. But I don't hear anything from them. And I think we need to hear from them before we move forward on this. That's my thoughts.
Councilwoman Baker.
Thank you, and good comments. I guess where I would probably wrap up is the innovative piece. I mean, I'm a little concerned that there's a gray area there of what's innovative and what is more treatment allowance. That, for example, with the Maumee again, the way that it's written, is that engage moms outside of clinic, coordinate care, measure of impact for 100 moms. It doesn't, I think that there's probably engagement with moms after they've been treated. I would hope that somewhere in the pipeline, we are following people who have been treated to make sure that they don't go back to an environment that puts them right back where they were. I know that was an issue that I dealt with a few years ago through the House. But more so than that, on your last page, number 10, we are really allocating a very small amount, which is the highest risk, but I guess I wouldn't call it highest risk. I would call it maybe cautious investment of models that are proactive. I'd like to see, as Councilman Gallagher wants to see more of perhaps what we're already doing, what others are thinking for care, but I would be excited about seeing models that Councilman Schron kind of briefly said. There are companies out there that are experimenting in this and experimenting in that and can show results from what they've done. I guess I would like to actually put more money into that, into really getting ahead of it so that we're more proactive and understanding why people get on it to begin with. I hear you on the prescribed and we get addicted and now we're trying to get people off. But there's a lot of, that's not prevailing anymore. Doctors are not prescribing like that anymore. So for us to be increasing, that is not really a scenario, I don't think, that exists today. Those increases are coming from other reasons outside of what doctors are prescribing because they've been reined in. So what can we do to understand why someone would get on these drugs to begin with? You could have a pile of it here and I wouldn't take any of it, yet it could be worth millions of dollars. And what is the difference there? What can we do in understanding the human behavior of why it is that we would want to experiment to begin with? And once you're addicted, you're always looking for stronger drugs. I mean, that's just part of it because you get immune to it. It doesn't affect you like it did when you first started. So I would rather actually see more money invested in the more experimental, but very cautiously experimental. I don't want to just invest in anything, but this team of people that come together understand the experimental piece and what has worked and what they would like to propose. And even coming back, I don't think it's a bad idea to come back to us and let us know what it is that, of this panel of 12, this is what they have come up with their research of what it is that they think would be a preventative measure based on their research, and come to us and explain that before any money is released. But that's where I would like to be. I think we do a lot in treatment. And I think if you brought the medical industry, like Councilman Gallagher suggested, we would hear a lot about what it is that we do in treatment. I was hoping that this would be an innovation fund, and innovating ways of being proactive to stop what we see as prevailing and increasing in drug abuse. That's my 2 cents.
Okay, thank you. Well, we have had a long and thorough hearing. We have a variety of views on the committee. We appreciate you coming in, and we will be in touch with you very shortly and work out what the next steps ought to be.
Councilman, final word, if I may. Word of thanks to every single member of this committee. Sometimes the voice you need to hear the most are the ones that don't agree with you. So we appreciate all the thoughtful comments today. Thank you.
Okay, thank you very much. And is there any miscellaneous business? Hearing none, and there being nothing further that holds our attention, we are adjourned, and the committee of the whole starts at 3:30. Thank you.